To announce the Zetzel Visiting Professor and Lecturer for 2020. The lecturer this year is our own Professor Thomas Lamont, who is, as you all know, the Emeritus Chief of Gastroenterology. Tom started his career at UCLA, where he did his residency, and then has the dubious distinction of having worked at every teaching hospital in the Boston area, except Tufts. And his fellowship at MGH was an attending at the Brigham, became the Chief of GI at Boston Medical Center, where I had the fortune to be one of his first fellows, and then came here to be the Chief of Gastroenterology in 1995. His career has spanned major achievements in all areas of gastroenterology. Many of you don't know this, but he was one of the first people that worked out how gallstones developed in the gallbladder. He published a paper that was the cover of Science magazine that illustrated why the stomach does not digest itself due to the interactions of mucins and the effect of acid on mucin structure within the stomach. He worked on the elucidation of toxins for C. difficile colitis and has been a leader in inflammation and immunity. These are just some of his scientific advances. He is a clinician, still sees patients today, and is a well-sought-after teacher, and has educated innumerable fellows and faculty. He's been a mentor to many. He's been a great friend to the GI division here at BIDMC. And the fun thing about this is that this Zetzel lecture is going to really be a look back at what has happened in the 50 years of Tom's career in gastroenterology. So it's a great pleasure to welcome Dr. Tom Lamont as our Zetzel.
Thank you, Nid, for those kind words. Let me get them through these first slides. I don't have anything to declare. That's my first slide. This is where I was an intern and resident in 1965. And at the time, the wisdom and knowledge that I was taught and received, I thought was really top level. And looking back now, I realize that all of it's been wiped away. So it wasn't incorrect, but it's been superseded by other information. So I'm going to try to give you some idea of the evolution of discovery in gastroenterology. By the way, I was a medical resident, but I didn't learn anything about nephrology, or there wasn't any nephrology really. We just had a diet. I think it's called the Giovanetti diet or something. That was it. And pretty much the same for the other specialties, and I never learned much cardiology anyway. So, I'm going to talk about major scientific discoveries and what they involve. I used to think, and a lot of people think, that discoveries are incremental, that knowledge is added like bricks to a wall, and you gradually build. It's actually more revolutionary, and there's a paradigm shift, which is a radical change in the way we do things. It's often disruptive, a word borrowed from technology, where a new thing blows up whatever was there before. And I'll show you some examples of that. And the major feature is resistance from the establishment. And I can tell you that Boston has a very powerful medical establishment, and the resistance to some of what I'm going to show you was quite remarkable. So, if you're interested in this topic, there's a wonderful small book, about 100 pages, by Thomas Kuhn, The Structure of Scientific Revolutions. It's one of those books where every sentence you start to underline and realize that it's really dense and terrific. And he laid down the ideas about paradigm shift, where you have to move away from something you've accepted for a long, long time and go on to something else. And when you move away from that original paradigm, that goes away. So the paradigm, for example, would be the original paradigm: excessive gastric acid secretion causes duodenal ulcers. This is what we thought at the time, up until about the late 80s, actually. And then gradually we learned that actually Helicobacter infection is the cause of the majority of duodenal ulcers. So let me just give an overview here about some of the things I'm going to talk about. There's dozens of things that could be discussed at a talk like this, and I'm not even sure I'll be able to get through the ones I put in the timeline here. I'm going to start with fiber optic endoscopy because I think that had the biggest influence on our specialty. It actually made the specialty and defines what it is today. When H2 blockers came out, that was a major advance, followed around the same time by Helicobacter, and then proton pump inhibitors, and then amazing discoveries in hepatology to the point where this disease is now cured. The ones I'm not going to discuss are on the lower left, and some of them have been discussed here recently. So, endoscopy. If you were a patient in 1820 in Italy, your doctor might approach you with one of these instruments. And it would certainly put the fear of God. I remember one time my dentist telling me, he knew I was a GI doctor, he said, Tom, never show them the instrument. And he had this trick of putting stuff in your mouth and you wouldn't see it coming. He said, patients don't like to see these instruments. And I imagine if your doctor came at you with that tall thing there, and he was going to put this in your urethra. This was a urethroscope. The other ones have different functions. I'm not sure. They're hinged and they look difficult. The GI tract is curvy. And the problem with these things, they're not curvy. So, believe it or not, this was the type of gastroscopy that was available when I was an intern. I wasn't an intern in the 20s, but Schindler was still active, and there were a few people in LA doing this test. You can see the scope there. It's the black line over his right arm. On the very right is Mrs. Schindler, who attended every endoscopy, and she was very clever at moving the patient's head. There was a leather obturator that got you into the esophagus, but after that it's a long metal sword, basically. So the head and neck had to be hyperextended. And as you know, the esophagus is straight. That's the only reason why this worked. It couldn't go around any curves, and it was really quite a difficult and brutal test. This is what we learned on. This, by the way, was done up until about 1985 or even 1990 at Boston hospitals. We had plastic ones that were disposable. We got rid of the so-called silverfish here. But everybody learned, every GI fellow, even internal medicine residents learned how to do proctoscopy for cancer screening. So what happened next? Somebody figured out how to bend light. So this is an old slide from 1842, an experiment that actually was a big deal in the field of optics. And it is a simple idea here. There's a bead of light is transmitted through a tank of water, this square thing in the middle, and you can see that the light follows the curvature of the water. So the light actually bounces off the side of the water. There's a whole study on this. This led eventually to the development by Narinder Singh Kapani of fiber optic cable. So this had a huge impact on telecommunications. But this same inventor then had the idea about endoscopy, and it was picked up by this man, Basil Hirschowitz. Hirschowitz was a fellow at the University of Michigan between 1953 and 1957, a native of South Africa. He was already trained in endoscopy in England before he went to Michigan, and he was trained in the Schindler type of endoscopy that I showed you. He could do those tests, but he realized that they were difficult and dangerous, and that we needed something better. So what happened next was a paper appeared in Nature by Hopkins and Capani that I just showed you, and it was entitled A Flexible Fiberscope Using Static Scanning. I'm not sure what those last three words mean, but what they developed was an endoscope that transmitted light through tiny fiberglass rods that were slightly bigger than a hair. So they had about 10,000 rods in a sheath, and they could transmit an image, and they could bend it. That was part of the paper. They could actually bend the scope. Hirschowitz heard about this paper from a cardiology resident that heard about it at Journal Club in London. He got on a plane, met Carpine and Hopkins in a pub, discussed their invention. They were very encouraging of him. And he went back to Michigan, this is still as a fellow, and built the first fiber optic gastroscope himself with help from Larry Curtis and Wilbur Peters, who were physicists. Physicists know how to make stuff. They're good at putting together things, especially fibers and optics and things. And here's Basil sitting with his first scope. GI fellows and other devotees in the audience will notice there's no wheels on the scope, so it's steerable. It's a side viewing scope, which makes it really difficult. And it really, compared to what we have today, it's barely an improvement, but it was the beginning of fiber optic endoscopy. So, like a lot of fellows and young researchers, you start with yourself. He actually scoped himself. He complained a little bit about the gagginess. He thought it was a bit of a trick to get it through the upper airway. It was safe, and he looked around in the stomach apparently, and then scoped a patient that had a duodenal ulcer. So this was the beginning in 1957. This was all by himself. There was no NIH grant, there was no K award or anything like that. This was unfunded research by a fellow with some physicists to make this incredible advance. He then hooked up with American Cystoscope Manufacturing, Inc. They made cystoscopes, but they were very interested in this, and this was the first commercial fiber optic gastroscope. Again, no wheels, but it had an air channel, and the optics were fair, and he could examine most of the stomach. Hershowitz himself published this paper in Lancet in May of '61, and the next to last sentence was throwing down the gauntlet. The conventional gastroscope, that was the Schindler scope, has become obsolete on all counts. This was not a hard sell. Some of the other things I'm going to talk about were met with opposition, but this was accepted, and by the time I was a fellow around 1971 and into the early 80s, gastroscopes then came into the Boston teaching hospitals. The opposition was not to the scope itself. It was to the idea of fellows leaving the laboratory and learning what sounded like a surgical technique. So the professors at the time were somewhat opposed to this. I think some of the older GI staff here will remember the, not scorn exactly, but sort of disinterest in doing endoscopy. One of the professors that was my mentor said to me, he said, once they taste blood, they're gone forever. Kurt, what do you mean? He said, once they take care of a bleeder with that scope, they won't want to do any more research. So that was the opinion of some of the academic leadership in Boston, research-oriented Boston teaching hospitals, but it caught on. So the impact is immense. I couldn't go through all the things. There's about 100 million endoscopies performed a year in the United States, not just by GI doctors. It turns out they have endoscopy now of the posterior cavity of the brain. So endoscopes, wherever there's a space or a virtual space, you can put an endoscope, including apparently the brain. In terms of what we do here, what we had at UCLA in 1965, and I'll go into this a little more detail. If somebody was bleeding, they probably went to surgery. Nowadays, of course, we take care of most of this endoscopically. Variceal hemorrhage was a fearsome occurrence in our hospital at the time. They mostly went to the porticable shunt, and now we have many other things. We used to have something, if you go down to the obstructive jaundice, called steroid whitewash. Well, I don't know if anybody's ever heard of this, but this was maybe a specialty at UCLA. If somebody had jaundice and you couldn't figure it out, like deep jaundice with high bilirubin and alkalis and lowish transaminases, and you were afraid of doing an operation, you would give them steroids for a week. And if the jaundice got better, that was medical jaundice, hepatitis or something, or PBC, and you didn't have to do an exploration. Most of our patients went to surgery. Most of our patients with obscure obstructive jaundice. And achalasia always required either a brusque dilatation, which was quite dangerous, or surgical myotomy. Now we're doing this through the endoscope at our hospital here. So the impact was massive. And I'd like to just tell you about a few things that are happening right here, right now. Just a peek ahead into the future. What's the future of endoscopy? And I think we're going to see a lot more of this type of approach called molecular endoscopy, where the scope isn't only to biopsy, but actually to analyze tissue for tumors using laser light scattering. This is a paper that was developed here by the investigators in our GI unit, whose names are listed there, working with Lev Perlman, a physicist in the GI division, and who works in photonics. And he actually hand-built this equipment. It's an echo of Hershowitz. On the left is a scanner that goes through the biopsy channel of the endoscope, emits light, and then measures reflected light from the wall of the esophagus. As the scope is withdrawn, the instrument turns, so it's like an internal CT scan of the esophagus, except it's spectroscopy, and this is able to detect dysplasia better than optical techniques in biopsy. So we're going to hear a lot more about this, and I think this will be something that will develop over your careers in gastroenterology. The first prospective randomized clinical study on artificial intelligence is being carried out right here. You'll see some names you might recognize here. The first investigators from China, but then we have Tyler Gerson and Jeremy Blisson-Brown, one of our fellows, and this was just published in Gut, and it shows the ability of artificial intelligence developed through game theory, game technology rather, to assist a physician doing screening colonoscopy. So the main goal, the main quality outcome of screening colonoscopy is adenoma detection rate. That's ADR. So we want to get all the adenomas and take them out and prevent colon cancer. And if you look where the arrows are, the polyp detection rate, PDR, using routine colonoscopy, this is the same patient studied twice, was about 29%, 45% with the assistance of artificial intelligence. So this will have huge impact on the practice of endoscopy, the detection of tumors, and many other things where this can be applied. So Mel Wilcox, who was the division director at the University of Alabama, where Dr. Hershowitz ended up, stated that essentially Basel created what GI is today, and this is true. When I started, GI was a reflective, diagnostic, minimally invasive, this is sort of like endocrinology. I actually thought I wanted to be an endocrinologist, then I thought I'd go into GI. And it's changed dramatically via this discovery. So let's switch gears and go to Australia. Pictured here, a medical resident, the tired-looking fellow on the left, Barry Marshall. He was rotating through the Royal Perth Hospital and asked his boss, or the head of the GI unit, if he was becoming interested in gastroenterology. He said, "I'd like a project." He had a curious mind. He was a good student. His boss referred him to Robin Warren, on the right, an assistant professor of pathology at the hospital. He went over one afternoon and they sat down and looked at slides that Warren had been collecting from patients. And he was looking at this silver stain of a spiral bacteria that was present in the stomach. Now, Warren knew that this had been not identified, but described for at least 100 years. There were many, many papers on this, including one from this hospital in the 50s from the surgical department, looking at bacteria in the stomach as a potential cause of ulcers. So what Marshall did when he sat down here, he realized that some of the patients that Robin Warren was telling him about were his own patients. He had learned endoscopy, so fiber optic endoscopy had reached the Royal Perth Hospital, and he was scoping patients and knew about the patients. So this lit a spark in him. He'd never done any research before. Warren had done a little bit, and the two of them teamed up and made a remarkable discovery. What they did was to correlate this finding with the presence of disease, in this case, active chronic gastritis. They published a paper, a letter to the editor in Lancet, which put together a case series, really, of patients with gastritis and with this curved bacillus. They went on then to make further correlations with other GI diseases, which I'll talk about. This and other papers were met with huge resistance by the medical establishment. And I'll tell you a little bit more about that. The infectious etiology of ulcer disease met with near universal rejection. I actually remember the Journal Club in a Boston teaching hospital near here, where this was presented, and it was universally rejected, and I have to say, I thought it was bumped. The problem was that in certain parts of the world, 80% of the population were infected. How could something that common be the cause of a disease like peptic ulcer that only occurs in, say, 1% of the population? Barry Marshall wrote in his note, or stated in his later publication, everyone was against me, but I knew I was right. So who was against him? The acid mafia. It's the acid mafia. When we were residents and fellows, we had to know a lot about peptic acid, gastric hydrochloric acid. We measured it. It was a quantitative test. It required a lot of work. So we were all about acid. And the acid people were definitely against Marshall and Warren. You know Koch's postulates. I'm not going to read them all. But look at the last two about the final step in Koch's postulates. You probably know what's coming next. The pure culture, when inoculated into experimental animals, must reproduce the disease. Think anthrax or diphtheria, easy kinds of tests. We actually use the same thing for C. diff. Microorganisms must be recovered from the diseased animal. There's the experimental subject. Barry Marshall himself downing a pure culture of Helicobacter pylori. So this is self-experimentation, similar to what Basil Hirschowitz did. And on the right, what happened, he was careful to pick a patient that he had studied and endoscoped and biopsied and cured. So he knew that the strain in there was treatable and curable. So he was careful. He drank this, and over the next several weeks developed severe acute Helicobacter infection with nausea, vomiting, dyspepsia. He stated that his halitosis was so bad, his wife told him he had to sleep on the couch. And he finally took anti-Helicobacter therapy with complete recovery. So this was then published in the Medical Journal of Australia about 1985. So this and much other evidence, like this paper, proved without a shadow of a doubt that Helicobacter was the cause of peptic ulcer disease. That doesn't mean that acid doesn't play a role. Acid still counts. An old dictum was, no acid, no ulcer. That's pretty much true. You can cure ulcers with proton pump inhibitors. But if you want to cure them permanently, then you have to do this. So this study in the New England Journal, in the run-up to the study, patients were cured with, in this case, Tagamet. And then they were randomized, the Tagamet was stopped, they were randomized to either antibiotics for 2 weeks to get rid of the Helicobacter. Oh, they all had Helicobacter to start with, or placebo. And you can see for yourself, there's a huge separation of these curves. And that most patients that had Helicobacter in their stomach had recurrence of ulcer by the end of the study. They were scoped 4 times during the study, and this and many other studies like this finally established the important role of this pathogen. It's probably one of the most common infections worldwide. And in some countries, the penetration rate is about 80%. For example, in Bangladesh, about 80% of children are infected by age 5. In certain parts of Bangladesh with poor access to clean food and water. The peptic ulcer rate is about 10%. And it turns out to be the cause of a number of diseases that are shown on this graphic. About 100% of patients with Helicobacter have some form of gastritis. It's not the only cause of gastritis, but it's a major one. Eventually, with chronic infection, gastric atrophy occurs. This leads to acrohydria, and in some patients to pernicious anemia with vitamin B12 deficiency. Then gastric cancers, it's thought that the majority of them result. This slide states that about 1% of infected patients will get gastric cancer. That's an overestimate. It's more like 1 in 1,000, even less than that. It's also the cause of malt lymphoma, which can be cured by treatment with Helicobacter. So lymphoma as an infectious disease that can be eradicated without chemotherapy, without removal of the stomach, by anti-Helicobacter therapy. And of course, gastric and duodenal ulcers. So this was a major advance, and coupled with something I'm going to talk about now, led to a big change in the way we treat ulcer disease. So they were finally justified. They won the Nobel Prize in 2005. A couple of blokes from Australia who had not done a lot of research at all, had, again, very little support. It was using equipment and tools that were right at hand. And I thought to myself when I was reading about this, I could do that. And we give this kind of study a lot to, of course, to our residents and fellows looking for a project. Here's a disease, and here's some information we've collected. Put them together and see what the correlations are. See if you can make a correlation. So this paid off big time. So back to UCLA, the treatment we had for peptic ulcer then and right up to about mid-70s was kind of primitive. It was basically antacids. We got to know the properties of antacids very well, what their side effects were and so forth. Something called the SIPI diet, which an older doctor at UCLA was very fond of. And this involved 2 ounces of half and half every half hour, alternating with an ounce or 2 of an antacid. It worked. The antacids were the active part of that for sure. Actually, milk is a great stimulant of gastric acid. It has protein in it. But a large number of the patients developed severe and semi-acute atherosclerosis. So it was finally abandoned. At this hospital, William Silen and colleagues developed a very unique approach to acute ulceration in patients in an intensive care unit, stress gastritis with bleeding. And he and his colleagues published a major paper that was followed in just about every intensive care unit in the country, whereby an NG tube was placed in patients that had blood in the stomach. Often they had sepsis and post-operative condition and so forth. The pH was measured, and antacids were titrated to bring the pH above 4. So this was in play when I came here, and it was certainly in play in the 80s. What we did for most of our patients with ulcers on the right hand of the slide, we internists became expert in these types of operations, not doing them, but handling the side effects that seemed invariable. So the types of operations, the first thing was to cut the vagus nerve, a vagotomy, and then remove usually the distal half of the stomach to get rid of the ulcer and to get rid of the acid-producing cells in the antrum. And then hook up the small intestine. As you can see, it's not very physiologic. There are lots and lots of side effects. And, it became a specialty, actually, post-gastrectomy syndromes. There were books published about it. and every GI fellow and house officer had to know information about these operations and their uses. Then it all changed. This garish slide shows these boxes of medicine that truly changed everything. Again, there was some pushback from the establishment. There was a couple of serious editorials in the New England Journal from Yale, from a friend of mine at Yale, who said that he did a quick survey of the inpatient service at Yale New Haven Hospital, and he was shocked that 56% of the patients were on, I think it was Prilosec at the time. And some of us commented, why is it so low? We used to kid around, it's actually piped into the room. You could open a valve in the room and you get it. So perhaps they were overused, but their effect and impact, along with endoscopy and treatment of Helicobacter, has changed radically changed what happens. So this is a graphic that shows, simplified, receptor-mediated hydrochloric acid secretion. So this became the target. We knew a lot about this before the development of the drugs, but it took drug companies to develop the answer here. This is not something that a medical resident and a pathology professor could likely sort out. So histamine was the mystery. It was known that histamine would stimulate gastric acid secretion. In fact, we used something called histolog to perform the test for acid secretion. But it was thought that there must be a special receptor for histamine, which eventually was called the histamine 2 receptor. The gastrin receptor was thought to be the major thing. And then finally the vagus nerve through acetylcholine, all of them having separate receptors with somewhat different signal transduction mechanisms, eventuating finally in the proton pump, which pumps a hydrogen ion into the lumen of the gastric gland in exchange for a potassium ion. So this all then went to drug companies, and Smith, Kline, and French started this program in 1964, and they selected James Black, who had already invented and developed propranolol. So he knew a lot about receptor-mediated activation, and he, in a small group of medicinal chemists at Smith, Kline, French in the UK, finally developed cimetidine, which hit the market in 1976. This was a big deal. This was the first billion-dollar drug. It wasn't known at the time that it was going to be a billion-dollar drug, but it was thought that it was going to be. It was a blockbuster drug. I was just starting my career as a faculty member, and I remember the AGA meeting, Digestive Disease Week at that time, was all about Tagamer. They were everywhere with it. People were just abuzz about this new drug. So it was a pretty easy sell, except for the overuse that I mentioned. So what James Black and colleagues did at Smith, Kline, and French was to study the histamine molecule and then make modifications. That methyl group on the imidazole ring there was found to be an agonist. So that was actually the first discovery. Once you have an agonist, and it did not stimulate H1 receptors, so they knew that they were onto something, and then it took them about 6 years to develop this molecule, which was Tagamet. They had a couple of earlier ones which were very effective, but when they were introduced into the market caused agranulocytosis in one case and pancytopenia in some other patients. So there were a few missteps, but in general it was a very successful campaign. And that eventuated into the Nobel Prize. You can see there's 3 people listed here. I learned that only 3 people can receive the Nobel Prize. I thought maybe it could be 4 or 5, but it's only 3, at least at that time. Or it could be 1 or 2 as well. Or it could be groups of people. But in this case, Sir James Black on the left, the discoverer of Tagamet, and also propranolol. So he had 2 huge drugs at the time used for many, many patients. Then on the right side, Gertrude Elliam and George Hitchings, and they discovered purine analogs that were used, and I'll give you a little bit more information about that. I'm going to say a few more words about Dr. Elliam. I put Dr. Elliam, she's actually not a doctor. Here's the information about her. She was born in Brooklyn, went to Hunter College where she graduated, or where she was accepted in at age 15 and graduated summa cum laude. She then looked for work. She wanted to go to graduate school, and she went to get a master's degree at NYU, but could not get into a chemistry doctorate program. And she wrote later that she was told at one interview by the head of the laboratory, this is an academic physician, academic investigator in chemistry somewhere in the Northeast, you might be qualified, but you would be a distraction in a lab full of men. So her first job, she worked for the A&P supermarket company, the Atlantic and Pacific Tea Company, testing the acidity of pickles. That's what she could find. Or she could be a secretary, she did that too. She judged the color of mayonnaise and checked the mold content of berries for sale in the supermarket. So she finally joined Burroughs Wellcome in 1944 at age 26. She never got her doctorate, as an assistant to George Hitchings, with whom she shared the Nobel Prize. So they were co-authors on all of these many, many papers and drugs that I'm going to show you that they discovered together, and they shared the prize. She never received a PhD, but was awarded many honorary PhDs, including one from Harvard. So their production, their contributions are these drugs. Now some of these were used heavily in gastroenterology. The top two, mercaptopurine, azathioprine, actually developed as anti-cancer drugs, but became used in scores of millions of GI patients in other situations for autoimmune diseases. They developed the antibiotic trimethoprim, acyclovir, and the others listed there. These are all actually still in use in some form or another, so they had a huge impact. They're all based on purine metabolism. So I became curious about how many women won the Nobel Prize, and the numbers are here. So 53 out of 943. And the graphic shows by 20-year segments that it's actually improving. So in the last 20 years, from 2001 to 2018, the number has increased, but it still has a long way to go. The trend is in the right direction, and I suspect it will improve over the next 50 years. That is the ratio to close the gender gap. I'll end up with a few comments about hepatology. I can basically summarize what we had then as nothing. We had AST and ALT, bilirubin and alkalis, familiar? They're still here. We had prothrombin and albumin. That was about it. We had no imaging of any kind, really. And I told you before, we used exploratory laparotomy. It was like a major diagnostic test. Or the steroid whitewash, which I mentioned. GI fellows and physicians became very good at understanding and describing cortical shunt. There were many, many of these operations. They were used on a weekly basis, and they're hardly done much anymore. But that was to treat varices primarily. There were few effective treatments for cirrhosis. I remember one of my teachers, I think in residency or perhaps early fellowship, saying that the prognosis of a patient with cirrhosis who had a complication such as bleeding ascites or infection was about the same as a person with stage 4 metastatic lung cancer, which at that time was not very treatable. So lifespan of a year or two for cirrhosis. We didn't know anything about hepatitis, I have to say. We just had infectious hepatitis. They were all infectious, really. We had short incubation hepatitis, we had post-transfusion hepatitis, and then other designations which weren't very useful. So this is the timeline about post-transfusion hepatitis, which has undergone a remarkable improvement and revolutionary treatments and diagnosis, so that the disease is basically gone. The first big hit was the discovery of the Australian antigen by group Blumberg about 1970. So this allowed, this is the rate of post-transfusion hepatitis in the United States in 1965. You can see it's about 22%. So the blood supply was not very clean. There were professional blood donors who, it turns out, had a 40% infection rate for hepatitis. And then it went along for a while, and then screening picked up with anti-HIV testing, because some of those were affected with hepatitis viruses as well. And then they started using ALT and AST to screen it. I don't know why they didn't think of that some 10 years earlier, because we had the tests. The only screen there was at the time was to ask people if they ever had hepatitis or if they used drugs. And finally, other tests which have pretty much eliminated post-transfusion hepatitis. So the HCV story is a very good story. It started really with the discovery at the NIH of the designation non-A, non-B hepatitis, which turned out later to be hepatitis C. The virus was identified, a test was developed, interferon therapy was started in the early 90s, and then the big revolution in the last 20 years, around 2014, approval of direct-acting antiviral drugs, and now we're talking about elimination of hepatitis C. So the initial early breakthrough was the discovery of the clone, isolation of a cDNA clone derived from a patient with non-A, non-B viral hepatitis. This was a massive work, and they found one single clone, a DNA clone, in a lot of sample, and this was performed by the authors listed here from 2 different companies. So this, again, is not the kind of thing that would be a simple project for a GI fellow, but required a lot of work over a long period of time. That, in turn, then led to isolation of the virus, genetic sequencing of the virus. And just a few words about the global burden. This is a huge disease with worldwide impact. About 2% of the world's population is infected. This map shows the redder the color, the more frequent the infection. And there are many different outcomes. The unusual thing about hepatitis C, after the tests were developed, that we could follow the fact that most patients had chronic hepatitis. 20% recovered, but about 80% went on to develop complications. Many remained asymptomatic, but many developed cirrhosis and carcinoma years later. And then this is just a timeline of the treatment, starting with the left, with interferon, first for 6 months, then for 12 months, and then the addition of ribavirin, which again is increasing the clearing of the virus, and eventually, as you can see with time, the introduction of pegylated interferon in founding the drugs that I mentioned, direct-acting antiviral drugs, and now to the point where currently about 100% of people with this infection can be cured by medication. A lot of this work has gone on here. I'd like to give credit to Afdhal and his colleagues who published this paper in the New England Journal in 2014, the first randomized trial showing all oral therapy with sofosbuvir and lidipespir, let's call it Harvoni, cure of hepatitis C in the New England Journal. So I don't know if you can see the numbers, but the cure rate or the elimination rate is about 99% with various forms of this drug. So we're at the point where this condition can be cured. And if I think back, we knew nothing about this when I was a house officer, and as a fellow, it was just coming in. So a huge improvement, let's call it. I'm going to stop with this. This is a quote that I've followed for a while. It's by Howard Gruber, who was a psychologist who studied discovery and invention. His major work was about Charles Darwin. He published a major book about his discovery. He says the power and the beauty of science, I think you substitute medicine there, do not rest upon infallibility, which it has not, but on corrigibility. Corrigibility, corrigere in Latin, to correct. We use the word incorrigible a lot, but corrigibility, science has to have corrigibility. And that's basically what's happened. The old paradigms have been corrected in large part. And as I said at the beginning, pretty much everything I learned about, at least about gastroenterology, I don't remember much about the rest of it, has been corrected. And the same will happen to you. So what you're learning now is as correct as we can make it, but it will be changed rapidly. So stay tuned. Thanks for your attention.